Share screen. Can you guys see my screen? Good. Okay, cool. All right. Week 2, treatment of mood disorders. All right, it's a pretty big topic, and we're gonna cover unipolar depression all the way to bipolar depression and everything in between. All right. Just quick review. Know the neuron parts, especially where the action potential goes down the gradient. Right. Know the difference between chemical neurotransmission versus the electro neurotransmission, which goes through the neuron. When one presynaptic neuron speaks to another postsynaptic neuron, that's chemical neurotransmission, right? That's where our medications work. So that's where neurotransmitters, dopamine, norepinephrine, serotonin, histamine, glutamate, GABA, all those neurotransmitters are going to work through that. All right. Once again, know what reuptake pumps do. Also know what vesicles are, VMAT. As the course goes through, we're going to talk about specific VMAT inhibitors, VMAT2 inhibitors, especially when we talk about tardive dyskinesia. And also when we talk about ADHD, all right? Know about degradation, how we have some medications that work on that. So good examples would be acetylcholinesterase inhibitors in Alzheimer's dementia and monoamine oxidase inhibitors in depression, all right? We don't really use monoamine oxidase inhibitors that much anymore, but they're still a very useful medication for patients who have failed on other medications, all right? Patients who have tried SSRIs, tricyclics, augmentations for other meds like atypicals, right? We're going to talk about that today. Monoamine oxidase, since it's actually working in all three neurotransmitters, are a very potent medication treatment for them, right? Obviously, there could be some interactions, drug-drug interactions and dietary restrictions, but if monitored correctly and the patient's aware, it's a very good medication to keep, still have up your sleeve just in case patients don't respond to other meds. Once again, know about the types of neurotransmission. Anterograde, which is classical neurotransmission going from pre to post or left to right, right? That's what most of our medications work on. There's also retrograde neurotransmission in which the postsynaptic neuron speaks back to the presynaptic neuron. Some examples I told you guys about were growth factors were one, right? Endocannabinoids were another one. Nitric oxide was another one, all right? Volume neurotransmission, the best example when we talk about ADHD is that there's no dopamine transport pumps in the frontal lobe. Therefore, when a presynaptic neuron spits out dopamine, it travels pretty far, right? It's like a pump. That's why it's volume. It goes out kind of like a cell phone speaking. You can reach another neurotransmitter, a neuron from far away. It doesn't have to be connected, all right? So that's really dopamine is a good example of that. Targeted psychotropic drugs, once again, know the G protein linked ones, 12 transmembrane, all right? Enzymes that break down, that stop the breakdown of neurotransmitters like MAOIs, which we're going to talk about later on. Ligand gated benzos, right? Voltage gated anticonvulsants, right? Mood stabilizers. We're going to talk a little bit about that today. Really know how neurons adapt to medications because that will explain why sometimes meds don't work, all right? Upregulation, downregulation, so they're the opposite of each other. When would a neuron upregulate? When you're antagonizing or agonizing it? What do you guys think? If you give someone a blocker or an agonist medication, when would the postsynaptic neuron upregulate? Upregulate means more receptors are formed, right? So it would be antagonist. So if you're blocking, right, your brain is so used to that stimulation of, let's say, of dopamine, that your dopamine receptors are going to upregulate, right? At the same time, they might also be sensitized, which means they become very sensitive. So you're going to have upregulated receptors and you're going to have very sensitive receptors. Remember, your body wants homeostasis all the time. So if it's used to a certain, influx of dopamine, and once you block that with a medication, your body's going to try to get that same, response again by upregulating and making those receptors very sensitive, all right? The opposite. Someone's abusing cocaine, someone's abusing amphetamines, right? In order for your brain to protect itself from excitotoxicity, it's going to downregulate, right? Or become less sensitive. So those are very important concepts I want you guys to know. All right. That explains why some medications work and some medications don't. Agonist spectrum, just know that, depending on, the medication, it could be a full agonist, right? Let's say, for instance, ADHD medication could be a full agonist. A partial agonist could be a medication for bipolar disorder or psychosis, right? Like Abilify, brexpiprazole, cariprazine. By the way, I'm not going to use branded names unless we talk about ADHD because it gets complicated. I'm just going to use generic names. So really know the generics, all right? So in the beginning, I'll say both, but in the test, they might just say the generic name of the med. So make sure you know that, all right? Because generics don't change. Brand names can always change. Antagonists could be from antipsychotic medications, right? Or sometimes for depression, we might use an antagonist sometimes. Inverse agonists, you have only a few meds. We'll talk about that in schizophrenia. We'll talk about that in mood disorders also. Any questions so far? No. Know the difference between pharmacokinetics and pharmacodynamics. Since you guys are FNPs already, some of you, you should have a general understanding of that. Pharmacokinetics, know the the interactions of what the body does to the medication, right? You should know the CYP enzymes, like I mentioned before. 1A2 is very important because that metabolizes a lot of our antipsychotic medications or mood stabilizers. 2B6, good example would be Wellbutrin, that's metabolized by 2B6. 2C9, that would be Depakote. 2C19, Lexapro, Zoloft, citalopram, Celexa. 3A4, benzodiazepines, some atypical antipsychotics. 2D6, beta blockers we use for akathisia or anxiety. Some antidepressants, 2D6, some antipsychotics, 2D6. All right. So those are the main ones that you guys should know. All right. Know what inhibitors, inducers are. We'll talk about that before. Know also that, patients genetically have certain, polymorphisms in their genes. So someone might be a fast metabolizer, right? Someone could be a rapid metabolizer. Know the difference between that, right? If someone is a rapid metabolizer, you give them a certain medication. Say someone's a rapid metabolizer at 3A4, you give them a 3A4 medication and you might have to go double on the dose, right? Or triple because their body is breaking it down so quickly. Except when? When would that be different? Good question. When would it be different if someone's rapid metabolizing? You would have to double the dose of the medication and it would have less effect. If the medication is a what, would it be the opposite? A prodrug, right? A prodrug means it's not active until your body metabolizes, right? Like tamoxifen, right, for breast cancer. Or some opioid meds, right, have to be metabolized to this active form for it to be. If it's a prodrug, it will be the opposite, right? If someone's a rapid metabolizer, they're actually getting a higher effect of that medication. So know that difference. If it's not a prodrug, then obviously a rapid metabolizer, the med is not going to work as it should. You need to double or triple the dose or more, right? If it's a prodrug, then obviously if someone's a rapid metabolizer, it would get more of an effect because more of that, parent compound is going to be converted to the other compound, which is a prodrug, and it would have more effect, right? Opposite, a slow metabolizer. Someone doesn't have enough CYP enzyme. Let's say someone is a slow metabolizer of 3A4. Obviously, you have to give them, less dose of the medicine because they would be very sensitive to it, right? How would you know that? What could you do? You would do a what?
Genetic testing?
No, genetic testing is not, no, because the thing is genetic testing will show you the best way to do it actually is plasma drug levels.
Oh, right, of course.
Right? Genetic testing, it'll show you, but it doesn't matter. But you're not going to know if they're taking let's say you do genetic testing, right? Since they're 3A4, fast metabolizer, but they also love to drink green tea, right? Or chamomile tea. I'm sorry, chamomile tea. Sometimes it washes out. It makes no difference. So you're better off just measuring the plasma drug level because you can get the net effect anyway. Sure, I do genetic testing to patients sometimes, but from a practical standpoint, there's so many other interactions that can happen that at the end of the day, it's probably just simpler to do plasma drug level. All right. Pharmacodynamics, what does the medication do, right? Is it an agonist? Is it an antagonist? Is it a partial agonist, inverse agonist, right? Which receptor does it bind to, right? D2 antagonist could be an antiemetic medication, right? We'll talk about that later. A D2 antagonist could be an antipsychotic medication, right? 5-HT2A antagonist could be an antidepressant, right? 5-HT2A antagonist could also be a medication to help with side effects of antipsychotic medications. So, know what the receptors do, because depending on what it is, it's an agonist or antagonist at specific receptors, it will do something different to the brain, right? So you should understand that. Like I said last week, it's a language. So you really need to start drilling that down, right? Someone has psychosis, so I'm not giving them an antipsychotic. I'm giving them a D2 antagonist, right? Someone is having akathisia from their past medication for psychosis. Therefore, I'm not just going to give them a D2 antagonist. I want to give them a D2 antagonist with a little bit of 5-HT2A antagonism, right? Does that make sense? Right? Someone needs to sleep. I'm not just going to give them Benadryl. I'm going to give them an antihistamine, right? Someone needs to sleep. I'm giving them medication that might be related to melatonin or Meltium, synthetic melatonin, right? I might give them a serotonin blocker, right? I might give them, you get the point, anticholinergic, or something that blocks, they're having nightmares, so I want to block norepinephrine, right? Giving them prazosin. I'm just throwing out different examples, but I'm trying to get you guys used to how I want you to understand the medications, all right? Don't just memorize the name of the drug and what it's for. Understand the mechanism of the drug, therefore you can kind of figure things out how to troubleshoot when medications don't work. All right. That's
Can I ask you, sorry,
yeah.
can I ask a quick question? Do you mind if we go back for a second? You were talking about the plasma
Mhm.
level testing. When would you do that? Like just with certain medications, or if someone's having like more side effects than you would expect? Like how would you know, and when would you say, hey, I should probably get a plasma level on this person because
Yeah, so I do it pretty much yet, like you mentioned, if someone's very sensitive to medication and they're having really bad side effects, and as long as they're taking it as prescribed, right?
Mhm.
They're not double dosing by accident or they have poor memory and double dosing, then yes, I would do it. I also would do it when the patient is not responding, right?
Okay,
Because they might be ultra rapid metabolized. So I do a plasma drug level, and then therefore I figure out, oh, you're taking it, but the levels are low than what it is, right? Or why should I do it when a patient is stable? That's one thing people forget about too. Why should I do plasma drug level even when patients are stable on the meds? I want to document that.
just make sure they're therapeutic, just have
Yeah,
it
because you
documented.
yeah, because you want to document like what dose it was that the patient did well on. For instance, lithium, right? We'll talk a
Right.
lot about lithium. We'll talk about that in detail later on. But regular lithium level. So I'm gonna give you guys a cheat sheet how to remember drug levels for the very for the drugs that have very sensitive drug levels, right? Because it's called a narrow therapeutic index, which means
Mhm.
that the amount that gets you well is very narrow, so that if you go above that, it's very easy to go above that. So most psychiatric medications, on average, have a therapeutic index of about 10 times for it to be toxic, right? 10 times means that you take 10 times the amount of Prozac, which is 600 milligrams, for instance, right? Because you can go up to 60 or 80 sometimes. Then you would probably have serotonin syndrome, right? Or you would die from that. With lithium, therapeutic index is only 0.6 to 1.2. Someone could hit 1.5, nanograms per ml of lithium. No, sorry, nanograms per moles for lithium. Sorry, and they can have shut down their kidneys already, right? They have lithium toxicity. It's very narrow, so you have to be very careful with those drugs. That's why sometimes. The irony behind lithium is that it's one of the few meds in psychiatry that have been shown to reduce suicidal thought, right? Or suicide in general. But the therapeutic index is also now so narrow that when you give it to them initially, if they take the whole bottle, they can also kill themselves. So it's kind of like strange. How can I give someone a medication that's very dangerous with overdose, but it's also been evidence-based to show that it reduces suicide? How would I solve that issue? What could I do?
Just, only giving them like prescribing for a really, really short period of time, or maybe, I don't know if you would make someone come into the clinic to like how frequently you see them and doing dosing in clinic initially, maybe?
Yes, I've done those things. That's great. So yes, I've had that where I only give them a week at a time. They have to come back and see me. Or
Hmm.
if they live with someone or have family members, their family members have to hold the meds, right? Because it could take like 1 or 2 months for that suicidal thought to go away. And during that first month or two, when they have access to a lot of lithium, you don't want them to, have lithium toxicity. So yes, you would do that. All right. And obviously monitor the levels to make sure. So remember, monitor when they're very sensitive, right? If they're having very sensitive side effects, you can do a monitor. You can do drug levels for almost every, I've done drug levels for almost every medication, except the newer meds, right? Antipsychotics, I typically do blood levels for those, right? A few times for SSRIs, I have, only if I wanted to make sure they were actually taking it or not, all right? But from a practicality standpoint, mood stabilizers, I always do blood levels for, and atypical antipsychotics, I always do blood levels for, all right? Do it when they're having sensitivity to it, do it when they're not responding, and do it when they're stable. I always advocate. Sometimes I call whenever inpatient hospitals like want to refer patients to me. It's funny because this isn't a practice that's done like across the board. It should be, and I'm a very big advocate of doing it. So when someone's in the hospital inpatient, right, and someone's being discharged from, I always ask them, hey, can you please do a drug level, right, which is not normal. People don't normally do that. They always wonder why. Why do you want that? Because I want to know that if they were stable on this dose and you're discharging them, let's say for instance, Abilify aripiprazole is 11 times a daily dose, right? 11 nanograms per ml per daily. So if someone's on Abilify 1 milligram and you do a steady state, it would be 11 nanograms per ml, right? If someone's on 10 milligrams of Abilify hit steady state, it would be what? What's 11 times 10? 110, right? Nanograms per ml. Once I know that that's, let's say for instance, someone's at Abilify 10 milligrams in the inpatient hospital, I want them to do a level because if they're a normal metabolizer and it truly is 110 nanograms per ml, right? Give or take a little bit, if they start destabilizing outpatient, I can do a leveling. I can say, hey, I don't know, maybe someone else added another medication and now you're metabolizing it a little bit faster. So I want to adjust that Abilify back to that same dose that gets that same level that you were when you're inpatient. Does that make sense? All right. Like I said, it's not standard practice, but it's, I always want to be ahead of the curve when it comes to practicing. So that's something I do with my patients, and a lot of 95% of my patients are stable. I'll just say that. All right. Because there are extra steps that I take to make sure that I'm very precise in my medication management. All right.
And that's something that insurances cover most of the time too? Like
Yes.
when, yeah, okay.
I've never had pushback from that. Never. Never. Yeah. Because you know what? I'll talk about schizophrenia, right? For schizophrenia, when someone gets hospitalized, and they've done studies in California, it costs the state about $1 million per patient. Hospitalization, loss of job, incarceration, right? Things that society has to do to keep this person well, right? Especially if they're treatment resistant. How much is the plasma drug level? $200. So if the insurance pays $200 for me to do a level to make sure that I'm actually being precise with my meds, or if I don't do a level and that patient decompensates, get it? The math, they've never gave, no, even commercial, never given me any pushback for that. Never. Yeah. Right. Again, we're going to talk about practical neuroanatomy. All right. So just if you look at these connections, just know what parts of the brain do a little bit. I want you guys to know that the raphe nucleus is the main cell body that creates serotonin in your body. All right. So a lot of our serotonin comes from, the raphe nuclei for serotonin. Right. Know that the ventral tegmental area is one of the main cell bodies that create dopamine. Another one is the substantia nigra. So those are the main two. It's not on here. Substantia nigra and ventral tegmental area are the main cell bodies that create dopamine. All right. Raphe nuclei is the main cell body that creates serotonin. All right. It's not on here, but locus, L-O-C-U-S, ceruleus, C-E-R-U-L-E-U-S, is the main cell body that creates norepinephrine. All right. Basal forebrain, it's not on here, BF, creates acetylcholine. All right. Nucleus accumbens is very important because that's the reward pathway. So when patients don't get enough dopamine and nucleus accumbens, that can be what? Symptoms of what? What do you think? If I'm telling you it's the reward pathway and someone who's having a mood disorder doesn't get enough dopamine there, what symptoms might you see? Starts with an A.
No,
Inability to feel pleasure. Anhedonia.
again, I don't, yeah.
Anhedonia. Know the A's, right? Anhedonia, inability to feel pleasure. Avolition, right? Someone's not motivated to do anything, just lay in bed all day, doesn't want to find work, doesn't want to do any goal-directed behavior. All right. Alogia has to do with their thought content. They're not able to really give. Like someone who has allergic speech or alogia, you ask them like an open-ended question and they'll say good, fine. Right? Apathy. They can care less if this is good or bad. They just kind of stay there, right? Apathetic. Someone just doesn't do anything, right? So usually the four A's are some signs that we see for depression, right? You're apathetic. You're not happy, you're not sad, you're kind of just like in between, right? Alogia, poor speech, right? Like, one or two word answers, right? Abolition, unmotivated to do anything. Don't want to get a job, don't want new relationships, don't groom yourself, don't brush your teeth, don't shower, all right? Anhedonia, inability to feel pleasure. How would you screen for anhedonia? What do you do? How could you ask them? I know this isn't a diagnostic class, but it's good to just tie it together and understand. You can ask them, hey, before you were depressed, what were some things you used to like to do? Right? Well, I used to like to walk in the park and sit down and watch the sunset, right? Okay. Since you've been depressed, have you done that? No. Why? I don't know. I tried it once and it just didn't feel the same, right? Or I listened to music, it just doesn't feel the same. Or I tasted food, it just doesn't feel the same, right? Inability to feel pleasure. Now, the other end of that, what happens if you stimulate dopamine too much in the nucleus accumbens, right? You can have addiction, right? You can have euphoria, people get addicted and, they'll seek that reward pathway again, right? Because of what? Downregulation, right? Someone takes cocaine and they take it and it feels good in the beginning, that first hit, right? What happens to those receptors? They're going to start downregulating, becoming less sensitive. So what happens? You need to get a higher dose of cocaine to get that same feeling again. Understand? That's why that concept of downregulation and less sensitivity is very important because that explains some behaviors of our patients. Why are they seeking higher dose of Adderall? I don't want 10, I want 20 milligrams now, right? Immediately. I don't want extended release. I want immediate release. All right. I ran out 2 weeks early. Can you give me another prescription? Maybe they're not using it the way it's supposed to be used, right? Maybe they're abusing it, right? Because they're hitting that nucleus accumbens, the reward pathway. Another name for nucleus accumbens is what? If you guys do the reading, that's with a V. Ventral striatum. Ventral striatum. All right. What's the difference between the ventral striatum and the dorsal striatum? Dorsal striatum has to do with movement, right? So if we're talking about the dorsal striatum, we're talking about the nigrostriatal area, which we talked about last week in the dopamine pathway, right? You need dopamine there in order to move fluid, like moving my hands now fluidly, right? Because I have dopamine working pretty well. You give me an antipsychotic, my movements start getting rigid and slow because you're blocking the dopamine in the dorsal striatum pathway, right? So what can you do? You might give me an anticholinergic medication. You might give me a 5-HT2A antagonist to balance it out, right? Prefrontal cortex, important because that's your frontal lobe, right? Judgment, executive functioning, right? Planning. We're going to talk a lot about that when we talk about ADHD medication, all right? Hypothalamus, thermoregulation, thirst, all right? That's important. Amygdala, your emotional center of your brain, right? People who have trauma or fear or PTSD, they have hyperactive amygdalas, right? It just so happens that serotonin has an inhibitory effect on the amygdala. That's why we give them SSRIs. And if someone says, hey, I'm having nightmares, I'm having flashbacks, besides blocking norepinephrine, right? Because that's too much norepinephrine is coming out of the what? The locus coeruleus. I also want to dull down their amygdala by giving them serotonergic medication, right? See, I'm targeting two pathways to help with those symptoms, all right? Okay, monoamine hypothesis of depression. So I just want to say that depression, as we know it in the DSM, is probably not what depression really is, right? DSM is good because it helps us speak a common language with our colleagues, but at the same time, it doesn't really do a good job of giving us the cause of our symptoms, right? It'll just give you subjective, this is what you see, or objective, this is what you'll see with the patients. But is it really capturing what's happening there pathologically? Probably not. All right. So what I'm saying is that depression, one of the, it probably has very different causes, and all we're seeing is just the end product. All right. That's why sometimes patients don't respond to a lot of our medication treatments. All right. There was an article that came out last year. I don't know if it kind of debunked that depression really wasn't supposedly due to a deficiency of monoamines because they've done CSF scans, CSF levels of monoamines, and they found that they were normal. They weren't depleted in patients who had depression. So it's possible that maybe those patients that they got they didn't suffer from this form of depression, right? There was it was called tyramine depletion studies they've done in the past, which tyramine is a precursor to serotonin, right? So what they did was they put patients on diets that depleted tyramine, and they weren't able to create enough serotonin. And guess what? Those patients actually did have depression. The interesting part is the only patients that had depression from that study were the patients that already had depression in the first place. Patients who never had depression and were given tyramine depletion did not develop depression, right? You can infer different things, right? Is there genetic predisposition? Probably, right? Is there something else that we're missing? Maybe there is, right? Again, we're only touching the surface. Mood disorders is such a broad, subject, and there's people that only specialize in that. I mean, I treat a lot of mood disorders, but I'm not a specialist in it, but I have a general understanding of it, all right? So one cause could be maybe some patients do have monoamine deficiencies, all right? That's why they respond to serotonin, norepinephrine, dopamine, all right? Back in the day, there was a medicine called reserpine, all right? It was a VMAT1 inhibitor, and it caused depression in some patients, all right? Remember, last week I talked about what VMAT was, right? It brings neurotransmitters inside the vesicles, right? Remember, any neurotransmitter that does not go inside the VMAT is not safe. It gets eaten up by an enzyme called what? Monoamine oxidase, right? There's MAOA and MAOB. Regardless, it doesn't matter. Whatever doesn't go inside that vesicle gets eaten up. So when they gave patients reserpine, it's a VMAT inhibitor. Therefore, once the neurotransmitters went inside that neuron, it didn't go inside the vesicle. Therefore, it wasn't safe. And what happens? All the monoamine oxidase was eating up all those neurotransmitters. And what happens? The end effect was that they had low monoamines, right? Think about what I just said. They gave them a medication, which is a VMAT inhibitor, which VMAT works on putting neurotransmitters inside of the vesicle, right? If neurotransmitters don't go inside that vesicle, it gets eaten up by monoamine oxidase. Therefore, you're wiping out serotonin, norepinephrine, dopamine, right? And those patients develop depression. So, with that observation, they were like, whoa, maybe depression is caused by deficiency of monoamines. Does that make sense? Right? Because if you deplete monoamines, Therefore, you would have less depression. That's why our treatment is a monoamine oxidase inhibitor, because it depletes the monoamine from eating up those neurotransmitters, and therefore you have an increase in serotonin, dopamine, norepinephrine. All right. Serotonin is important because it has some anti-anxiety properties, like I mentioned. It dulls down the amygdala. Therefore, if someone has anxiety with depression, that might be a good treatment, right? SSRI. What is the effect size of SSRIs in depression? Do you guys know? What is the effect size? It's a mild effect size. That's my hint. 0.2 to 0.4, right? Just for comparison's sake, the effect size of Adderall for ADHD is above 1.0. Think about effect size now. So you're taking someone a medication for depression, the effect size 0.4, which is mild, which is actually equivalent to psychotherapy, CBT, right? That's why some people say, why are you taking medications for depression, right? It's just as effective as CBT. There's some truth to that. The problem is when they did further studies of patients who had moderate to severe depression, the effect size actually separated from CBT a little bit more. All right. So what I'm saying is that if someone has mild depression, you necessarily do not have to put them on medication. All right. You can try the therapy route first. If you want to do therapy yourself, if you have training in that, or if you want to refer them to a therapist, that might not be a bad option, right? Because the side effects are not going to be the same as if you're giving someone SSRI, sexual dysfunction, weight gain, right? Apathetic syndrome from it, from giving too much 5-HT2A agonism, right? But once someone has moderate to severe depression, then it separates more and it has more effect. Now, the effect size of SSRIs for anxiety, even though we're not talking about anxiety today, is 0.4 to 0.5, a little bit more actually. So I would argue that medications that we use as antidepressants are actually better anti-anxiety medication. So if someone's, why is someone giving you Zoloft for, anxiety? Isn't that an antidepressant? It's actually not. It's actually more effective in anxiety than it is for depression. All right. Malfunctioning brain circuits in depression. All right. Like I mentioned, prefrontal cortex or dorsolateral prefrontal cortex, DLPFC. All right. That has to do with sustained attention, right? So there's poor concentration, mental fatigue, guilt, worthlessness, suicidality, right? So, the proposed malfunctioning brain circuit is actually in the prefrontal cortex. So if a patient comes to you and they have those symptoms, you would imagine in your mind, I have to fine tune the frontal lobe, right? Or prefrontal cortex. Like I mentioned previously, nucleus accumbens has to do with anhedonia, decreased interest, low motivation, or abolition, right? The striatum, remember, it's the movement pathway of the brain, psychomotor fatigue, right? I feel like I'm walking in quicksand, right? I have a hard time getting out of bed, right? It takes me 20 minutes to get out of bed, right? Hypothalamus, I can't fall asleep or I'm sleeping too much. I don't feel like eating or I'm eating too much, right? That's the hypothalamus being affected by depression, right? Cerebellum, psychomotor effects, right? Balance, gait. Any questions? I'm kidding, oh my God. I know it's a lot of material, but stay with me, all right? It'll make sense. Okay. This is the reason why sometimes it takes a little bit longer for our medications to work. Have you guys read this on the style book and tried to watch the videos online? Okay. It has to do with downregulation of the serotonin receptors, all right? So when they do postmortem studies of depressed patients, there was one thing that they found, right? That a lot of patients who had depression, who died from suicide, actually had more receptors than they had neurotransmitters, all right? So that made people kind of infer that maybe, this one of the causes of depression could be this upregulated receptors. Now, what causes upregulation? Like I told you guys, if you understand upregulation, downregulation, not enough neurotransmitters, right? So imagine now over time, decades or years, someone's neuron is not producing enough serotonin, dopamine, norepinephrine, right? What happens to that postsynaptic neuron? It's not getting enough. So it's going to upregulate and become very sensitive, right? So you actually have more receptors than you have neurotransmitters. So what we're doing in essence with the medication is that we're trying to balance that out. We're trying to downregulate those upregulated receptors by increasing the amount of serotonin in the cleft, right? I'm just using serotonin because that's the example that's here, right? So the presynaptic neuron is what you see here on the left, right? The postsynaptic neuron is just what you see with the pink receptors on the very right side, all right? So if depression really was just not enough neurotransmitters, right? Once you give someone an SSRI, that already stops the pump and that increases serotonin there in the clot, right? Wouldn't someone have response already, right? Within hours, once you give them that medication? But that's not what happens, right? How long does it usually take for SSRI medications to work? How many weeks, usually? What do you think?
4 to 6 weeks.
Yeah, usually 4 to 6 weeks, right? Usually it's 3 to 4. Prozac, because it has a very long half-life, is usually 4 to 6. So usually I'll say Zoloft or Lexapro. You can expect between 3 to 4 weeks. Some people respond a little bit earlier, some people later, but usually 3 to 4 weeks. If Prozac has a half-life of about a week, it takes about 5 to 6 weeks for it to work. All right. So what happened is the reason why it's taking that long for the meds to work is you have to constantly give those medications to constantly prohibit the SERT pump, right? The serotonin reuptake pump to bring in serotonin. And what happens over time, that postsynaptic neuron, since it's getting innervated by a lot of serotonin now, is going to start downregulating those receptors, right? Which could take weeks. Remember, it's G protein mediated, right? G protein takes all those messengers to work. So therefore it takes time for it to work, right? It has to go inside the nucleus of the postsynaptic neuron, transcription, translation has to happen, right? And all that takes time to work, right? Does that make sense? And the receptor is the 5-HT1A receptor. So the 5-HT1A autoreceptor is actually in the presynaptic neuron. If you look at the dendrites where the hair follicles are looking like in the front, right? What happens over time? You increase serotonin and they're going to keep sticking to those 5-HT1A receptors. Initially, is the 5-HT1A is an autoreceptor. An autoreceptor stops the release, right? In the beginning, yes, you're giving someone SSRI, it's actually going to inhibit release of serotonin initially because it's going to hit that autoreceptor. But what happens over time? That autoreceptor is going to downregulate and desensitize. Therefore, it's going to shut off. So after a couple of weeks, that 5-HT1A autoreceptor in the presynaptic neuron is going to stop working, and then that presynaptic neuron is going to flood that postsynaptic neuron with serotonin, and therefore that's going to downregulate. Does that make sense? So initially, you give someone an SSRI, right? It's going to increase serotonin in the synaptic cleft, in between where that red circle is in the middle. Serotonin is going to start coming out, and it's going to start binding to the 5-HT1A autoreceptor in the cell body in the very front of that neuron. Over time, because of downregulation, it's going to start downregulating and becoming less sensitive to the point where it shuts off, doesn't work anymore because you're just constantly stimulating it with serotonin. Once that autoreceptor is off, that presynaptic neuron is free to fire serotonin, and then it's going to downregulate that postsynaptic neuron. Does that make sense? Need me explain it again, or is it clear?
Yeah.
Clear? Okay. Another hypothesis is the HPA axis, right? So it stands for hypothalamic pituitary adrenal axis, all right? So it starts first in the hypothalamus, and this hypothalamus will secrete something called corticotropin releasing hormone, right? That's going to act on your anterior pituitary gland. Your anterior pituitary gland is going to secrete adrenocorticotropin hormone, which is going to stimulate the adrenal gland in the kidneys, all right? In a normal reaction, right? You see something that scares you, I don't know, you see a raccoon outside, right? You start freaking out. Your HPA axis is going to start working and you're going to start secreting cortisol. Why is that important? Because cortisol is your stress hormone, right? It's going to cause your body to get ready for fight or flight response, right? To get away from that raccoon. Over time, what happens? The cortisol, if you're constantly, let's say for instance, someone's being abused, right? Constantly. I had a patient, female, when she was young, she was being abused for like a year straight by one of her uncles. All right. She developed depression. Why is that? Because she was constantly in a fight or flight response all the time. Her uncle was abusing her every day, right? And what happens is that cortisol, so in a normal person, the cortisol will cause a negative feedback loop, right? Your cortisol will actually bind to receptors in your brain and it's going to tell it to shut off. So let's say, for instance, you see a raccoon, goes away, you run away from it. The cortisol is going to reach your brain. It's going to hit an autoreceptor there, and it's going to say, hey, shut off the CRH, right? CRH is going to shut off, and therefore the cortisol is going to stop releasing, right? But if you're constantly, let's say you're locked in a room with a raccoon, right? And you're there in the room for weeks and you're petrified of raccoons, what's going to happen? The cortisol is going to keep releasing, and that's going to cause atrophy of your hippocampus, right? Atrophy of parts of your brain. Your frontal lobe will also start atrophizing, right? So what's going to happen is you're going to have, anxiety. You might even lead to depression. Why is it that patients who have depression eventually develop anxiety, or people who have anxiety for a long time eventually develop depression, right? It's kind of like chicken or the egg. They both kind of, it's very rare that you see someone that only has one, right? So the good news is sometimes one med can treat both, but sometimes it doesn't. So, hyperfunctioning HPA axis can lead to depression, right? That's a good example of why chronic stress, right? You hate your job, you're constantly going to work, eventually you become depressed and you get very anxious, right? That's because you're always getting cortisol release when you're sitting in your desk and you hate your job and you hate your boss, right? Questions with that? No? Okay. They tried to develop meds to work on that axis, but from last I heard, they weren't that effective. Like I said, maybe the subset of patients that have hyperactive HPA axis were not being treated, right? Because like I said, depression has so many different causes. It's called it's heterogeneous, right? A lot of our disorders in psych are heterogeneous, right? The DSM gives you criteria for what they are, but patients might have those same symptoms, but the cause could be totally different, right? Because DSM doesn't tell you the cause. It just shows you what you see, the downstream effect of it, right? Like a sneeze, right? So many things can cause a sneeze. The sneeze is what you see. It could be many different things, right? It could be COVID, it could be allergies, it could be a brain tumor, right? Again, chronic stress, systemic inflammation. Okay, so we have, we talk a lot about neurons, but there is a move now towards glia. So a lot of newer treatments now are actually going to work on glia. So glia are like supportive cells in the brain, right? So I know we talk a lot about neurons, but you also have cells that are called glial cells, right? Glials are what make the Schwann cells. They make support. They're the support that holds our blood-brain barrier together. So microglial activation, as someone who has chronic stress, going back to what I said, you hate your job or you're exposed to adverse childhood experiences, right? It activates microglia in your blood-brain barrier, and what the microglia do is it secretes cytokines. And when cytokines come out, right, that causes your blood-brain barrier, which is normally non-porous, to become porous, right? So that means that things can go inside that you don't want to go inside. And what happens is once you have the inflammation, you have macrophages, monocytes that go inside and they start doing damage to your brain, right? So pretty much it's like an autoimmune response. Chronic stress and inflammation leads to microglial activation, cytokine production. You don't have to memorize all these different cytokines. It's okay for now. And that causes inflammation, which will cause your white blood cells to go inside your brain and cause damage there. All right. Again, all of this isn't in a vacuum. A lot of times that will probably give you a hyperactive HPA axis as well. And all this is happening at the same time. All right. Obviously, inflammation, you know, is something that makes people not respond to medications, right? There have been studies out there that patients who have been resistant to antidepressant medications, we put them on a diet regimen and they lost 10 pounds and they actually responded to their medication, right? Someone who has obesity or someone who, has chronic inflammation doesn't respond to our medications, right? Imagine you're giving someone SSRI, but at the same time, the microglia is activated. So it's kind of like a wash, right? You're trying to increase BDNF, brain-derived neurotrophic factor, by giving them SSRIs. But at the same time, their body's attacking their own neurons from the microglial activation, right? From the chronic inflammation. So sometimes, you know, healthy diet, psychotherapy, right? Omega fatty acids, all right? There are some studies also that anti-inflammatory medication might be good adjuncts for antidepressants, right? There's also studies now that Ozempic, right, GLP-1 agonist, has been effective in treatment-resistant depression, right? They give patients Ozempic, and then they give them antidepressants, and before the antidepressants were not working, but with the Ozempic, it's working now, right? That all has to do with the very complicated, inflammation and how it can really be damaging to your brain, right? I know in psych we really focus on the brain, but in reality, it's all the body, doesn't work in a vacuum, right? That's why you have to collaborate with, most of my patients, I collaborate with endocrinologists, right? I collaborate with, FNPs or internists because we have to all work together because their treatments are not going to work if the patient's psychotic, right? And my treatments are not going to work if the patient doesn't have a normal BMI and is not medically stable, right? So it kind of has to go hand in hand. You guys have to work together. Any questions for that? No. Even though this isn't a diagnostic class, this is a good way to, remember what the symptoms are of major depressive disorder. All right, SIGI caps, right? Issues with sleep. Some people sleep more, some people sleep less. Interest, right? Anhedonia, avolition, guilt, right? Why is extreme guilt very dangerous if you don't treat it? What'll happen? Someone's at risk for what? If they feel very guilty, they're at risk for what? Killing themselves, suicide, right? Especially if they feel, I usually ask patients if they have depression, do you feel like, that you're a burden to your family because you're constantly in the hospital? and they have to take you to me, right? Yes, I do. Have you ever felt that maybe their life would be better if you weren't around? Yes, I do. Right? But if I would have asked them, are you suicidal? No, I'm not suicidal. Get it? But I'm asking it indirect. And then I'm getting that, maybe they would kill themselves. They feel like they're a burden to their family, right? A burden to whoever, a burden to their loved one or to their friends, right? That's very important to screen for that. Sometimes patients might have guilt, but they have energy. They have no energy. So they would kill themselves, but they have no energy. Now, what happens if you give them an antidepressant, they get a spike of energy? Then they might kill themselves, right? Because remember, our treatments treat a bunch of symptoms, but those symptoms don't subside at the same time. So the most dangerous part is you help them with their energy, their concentration, but then they're still suicidal, right? In theory, I wish I could get suicidality to go down at the same time. It doesn't work that way. So sometimes it's actually protective. If someone's depressed and they have, a lot of neurovegetative symptoms, neurovegetative means they have no energy, they feel like they're walking on quicksand and they're suicidal, they're not going to kill themselves because they can't get out of bed. But once you give them that energy, they're at risk for suicide. So be careful. But that's why there's that black box warning or that box warning, and you have to see patients more frequently. All right. And have the family members watch them, especially ages 18 to 30. All right. These are the medications for MDD. All right. Know the generic names. So no sertraline, citalopram, the generic names. All right. I'll just throw out some, clinical pearls for each one. I like to use sertraline, especially in older adults, because there's a lot of studies that show that it's safer when it comes to cardiac medication. So when it comes to cardiac risk, sertraline tends to be the safest. All right. A lot of studies of that. People in the ICU and they have depression and the go-to is sertraline, right? For perinatal psychiatry, sertraline is also one of the go-to medications because not a lot of it goes to the breast milk. So therefore, if someone's breastfeeding, it could be a fairly safe medication, right? I say fairly because no med is 100% safe, all right? Citalopram is is an enantiomer of escitalopram. They're mirror images of each other. Just know that citalopram, you tend to have to go higher dose. All right. So citalopram goes to 40 milligrams, escitalopram goes to 20. All right. The difference to know is that they're both can cause QTC prolongation. All right. So watch out. All right. It can lead to torsade de pointes. And what happens is they can have a fatal arrhythmia. All right. So make sure that if you have someone on escitalopram, 20 milligrams, you probably should do an EKG or refer them to get EKG done once a year. All right. Because what happens if someone is on escitalopram and that's metabolized by 2C19, by the way, right? And they get put on a medication that's a 2C19 inhibitor, right? Now that dose is going to go up and therefore they're at high risk for arrhythmia, all right? Or there are other medications that can prolong QTC, all right? Citalopram, 40 milligrams, you should do yearly EKGs, all right? The reason why they're used a lot because they tend to be one of the cleaner SSRIs. Cleaner means that they're very just only serotonergic and they don't have CYP enzyme interactions. They themselves are not inhibitors, right, or inducers of CYP enzymes, right? Paroxetine is. Paroxetine is a very strong inhibitor with a short half-life, right? So is fluoxetine. Fluoxetine probably more dangerous because it's an inhibitor, very strong inhibitor with a long half-life. So if you put someone on fluoxetine, right, and it hits steady state, that fluoxetine is staying in the system for at least 5 weeks or a month. So therefore, even if they stop the dose of fluoxetine and their primary care doctor prescribes them, I don't know, 3, 4, 2D6 medication, if they don't know that they were on fluoxetine, they can get a higher dose of that. That's why it's dangerous. All right, so be careful about that. That happened to me with a patient where they were prescribed the medication for their anxiety by their primary care doctor, right? And I was like, what med did they prescribe me? I don't remember. I can't tell. I don't remember where it was. I was like, all right, let's put you on Abilify, right? They had agitation. I put them on Abilify 5 milligrams and they started having akathisia. Then they remembered that, oh my God, I was on Prozac before. Okay, so that 5 milligrams is probably 10 milligrams of Abilify because remember, fluoxetine is a very strong inhibitor, right? With a very long half-life. So you have to make sure that it washes out. I mean, you can still get them Abilify, just cut it in half, cut the dose. All right. Remember, if they were on Abilify to hit steady state, normal blood level will probably be 110, right? Because it's 10 nanograms per ml, 11 nanograms per ml for each milligram of Abilify. So if I would have done the level over that patient, it probably would have been way more than that, right? Higher than 5 or 55. Right. Fluvoxamine is an SSRI, but it's only FDA indicated for OCD, obsessive compulsive disorder, right? So be careful with fluvoxamine because it's a very potent 1A2 inhibitor, right? 1A2 is important because some of our antipsychotics, clozapine, which could be fatal, Be careful with that. It could be done, but just be very careful. Makes you do level. Olanzapine is 1A2. Acenapine is 1A2. Melatonin is 1A2. Caffeine is 1A2. Right? Haldol is 1A2. Tylenol is 1A2. See what I'm saying? There's a lot of interactions with psychiatric medications, a lot of other medications. So I'm just giving you examples that I've seen in clinical practice, right? So a college student was given fluvoxamine for OCD. Now she had a panic attack. I think I talked about this last week, right? Luvox. It's a 1A2 inhibitor, right? Patient is taking over-the-counter melatonin. Now they're overly sedated in the morning because they gave them Luvox, because serotonin is a 1A2 medication. So that 10 milligram of melatonin could have been way more than 10 milligrams, right? Someone who's taking Tylenol for pain, I know there's a 4 gram, or 3,500, milligram limit, depending if they're inpatient or outpatient. But if they're taking a lot of it, for pain, if you give them an inhibitor, it could be fatal, right? So just be careful. Paroxetine, used to be used a lot because it's very anticholinergic and antihistamine, but I don't use it a lot anymore because the risk of sexual dysfunction and weight gain and sedation are much higher because it's a very potent antihistamine, anticholinergic. All right. So I don't use Paxil unless the patient's already stable on it. But if a patient's older, let's say like geriatric patient, like 65 and older, I usually try to get them off of Paxil, right? Why give someone who has a risk of, mild cognitive impairment or dementia, if there's a family history, and put them on Paxil, which is anticholinergic, right? You want to reduce that burden. I would probably switch them to Zoloft, right? Because I said there's a higher likelihood of them being on cardiac meds as they get older. Zoloft tends to be safer, all right? Zoloft, though, does have a lot of GI side effects. That's why we call it squirtuline, because it can give a lot of diarrhea. All right, squirtuline. Venlafaxine, SNRI, all right? So SNRI, you're increasing norepinephrine, it can increase blood pressure. So make sure you do blood pressure, all right? If someone has hypertension and it's controlled, yes, you can give them an SNRI, but just be careful and make sure you monitor, all right? Duloxetine is also an SNRI, but it's also used a lot in patients who have neuropathic pain. So you see a lot of neurologists will give someone who has depression, neuropathic pain, duloxetine, right? Just for perspective, venlafaxine is classified as an SNRI, but the ratio of how it blocks serotonin to norepinephrine is actually 30-1. So I'm going to give you an example. For every 1 norepinephrine transport pump that it blocks 30 serotonin pumps. So you need a lot of venlafaxine for it to actually be an effective SNRI. So if someone says I'm on like 75 milligrams of venlafaxine, I'm like, technically I'll just give you fluoxetine or Zoloft, because at that dose, it's technically working as an SSRI. All right. And the reason why I don't like to use SNRIs is because they tend to have shorter half-lives and it's very hard to get off of them. Patients get brain zaps, right? They have flu-like symptoms on SNRIs. So again, I'm just going by, you can use them. I have a lot of colleagues that like to use them, but in my personal practice, I don't use a lot of SNRIs unless someone is on it already for neuropathic pain by the neurologist. I'll keep it and I'll adjust it, but I've had nightmare stories of getting patients off of it that I'd rather not put them through that process. Because sometimes I have to go to a compounding pharmacy to get them off of Effexor. One time it took me a year to get a patient off Effexor, getting them off 37.5 milligrams of Effexor. So there's something called a hyperbolic taper. All right. Hyperbolic taper means that if you reduce the dose, let's say, I'll give an example, right? Venlafaxine, 150 milligrams, right? You would think when you go from 150 milligrams to 75 milligrams of Effexor, right, that you're cutting that dose in half, that it's probably only blocking half of your serotonin reuptake in norepinephrine transport pumps, right? It's not. What happens is that, I'm going to just give you an estimate, right? Getting from 150 to 75 might be easy for a patient, right? Because that only might remove, I don't know, 25% of the medication from the transport pump, right? Once you go from like 50 or lower, or 37.5, the drop is so drastic that patients have a lot more withdrawal symptoms. So a hyperbolic taper means that going from 150 to 75, you can go fast and you can make big jumps, right? Let's go down by 50 milligrams to 25 milligrams. But going off from 37.5 to 0, going to 0 milligrams is very difficult because that's where the drastic drop is going to be. And you have to really go every other day dosing, every 3 days, or if they can't tolerate that, go to compounding pharmacy and get even smaller doses. All right. That's called a hyperbolic taper. Amitriptyline is a tricyclic antidepressant. All right. Tricyclic tends to not be used as much anymore because it's kind of like a dirty drug, which means that it works on sodium pumps, it works in calcium pumps, it also works in serotonin or epinephrine pumps, it's also antihistamine, anticholinergic. Sometimes, you don't want that extra, you know, pharmacodynamic issue, right? If I just want to treat depression and increase serotonin, it might be overkill to give them a tricyclic, right? But if someone's having neuropathic pain, they're having insomnia, and they're having depression, maybe I might need blocking some of the pumps. I might need some of that antihistamine for insomnia, and I might need the SSRI from it. Get it? But if someone doesn't have these comorbidities, you're probably better off just targeting SSRIs, right? Giving them, sertraline, Prozac, or whatever, all right? So tricyclics, we still use them, but not as much because what happens? If people can overdose on them, right? So people overdose on tricyclics usually if you do an EKG in the hospital, they're going to have a widened QRS interval, right? If you see a widened QRS interval, you know they probably overdosed on tricyclic antidepressants, all right? They usually give them bicarbonate to save their life. Any questions? You don't have to memorize the dosing, all right? Just understand, the classes of the meds. Know that if someone has some neuropathic pain, you might want to target, norepinephrine at the same time. Remember, norepinephrine and dorsal root ganglion of the spinal cord is inhibitory. So what happens is when the pain pathway, say I stub my finger, I hit my finger with a hammer, right? That pain pathway has to go up to my brain, right? In the dorsal root, norepinephrine has inhibitory effects. So by increasing norepinephrine, it's actually going to dull down the pain pathway. I'm not saying you can hit your head with a hammer if you're on venlafaxine, but it dulls down the pain pathway, all right? Same as the tricyclics, right? The tricyclics that work a lot in norepinephrine, like nortriptyline. That might help with pain, all right? Just know the overdose risk of tricyclics. Know the very hard taper of withdrawal with the SNRIs. Another important fact, SNRIs, they can cause something called spontaneous liver injury from the medication. So I would probably do a liver function test, every 6 months or so, right? So if someone has impaired liver functioning, I probably would not put them on SNRIs, all right? Any questions? No.
I just
Yes.
have, yeah, sorry, question. So just, looking at all these like different interactions and what can potentiate other things, do you have like, what's your go-to? I mean, like I know, like when you're researching or looking to find interactions. I mean, I have Hippocrates on my phone that I use,
Use
and I
that. Yeah, the Flockhart table is very good too. I use the Flockhart table. Yeah.
I'm sorry, what was that?
Flockhart. I think we uploaded it on the website. Flockhart. 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 Flockhart table.
Okay. All right. Thank you.
No problem. Hey, Robert, how's it going?
Not great, actually. I'm having a terrible day at work, but
Yeah.
it's over now.
All right, come see me, man. What's your insurance? We'll talk about it.
Yeah.
Psych is the only profession where technically you can ask someone how they're feeling, how they're doing, and you can bill them. Hey, listen, it wasn't a formality.
Yeah.
Sending you I'm sorry, Robert. You should take off, man. Whenever you're doing a lecture like this, especially this is a big subject, by the way. Mood disorder is a very tough subject.
I know. So I'm supposed to be allowed to leave early on Fridays. But someone overdosed in and there's nothing I can do about it. It's just like the sky is falling all day today. So
Listen, the good news is this is recorded, so you can watch it over again.
mhm.
Okay, side effects of antidepressants, all right? SSRI, SNRI, all right, obviously sexual dysfunction. Some of the proposed mechanisms as to why some SSRIs can cause sexual dysfunction. Paxil is a nitric oxide inhibitor, all right? Nitric oxide, you need that for your cells, your vessels to dilate, right? So Paxil, since it's inhibiting nitric oxide, which also happens to be an anterior grade neurotransmission, it can cause sexual dysfunction. That's one of the meds that are very notorious for that. All right. Sometimes we use Paxil or paroxetine off. I've used this off label for patients who are hypersexual. All right. Someone who's hypersexual, who has history of sexual assault, and you want to really kill their sex drive, especially inpatient, we've used Paxil. All right. Off label, obviously. All right. SSRIs, when they hit the 5-HT2A receptor, it actually downregulates dopamine. It brings down dopamine levels. So if you give someone an SSRI, remember, the problem with SSRIs and the reason why they have a lot of sexual side effects is because they're not very specific. So if you're increasing serotonin in the synaptic cleft, if you look at the STAR book, there's I think there's like 15 or 17 that we found different serotonin receptors, right? Serotonin is free to bind to all those receptors. So you're increasing serotonin you're not being tactful, you're not being precise for your treatments. It might hit an inhibitory receptor, it might hit an excitatory receptor. If it hits an inhibitory receptor, it inhibits dopamine, right? Dopamine is for pleasure. It might cause anorgasmia, right? It might cause an ability to feel pleasure, an ability to be aroused. So that's why sometimes SSRIs are not the best treatments, all right? And sometimes we have to adjunct. So I might give someone an SSRI, and I might give them a 5-HT2A antagonist like trazodone, right, to help with sexual dysfunction, right? Or I might give them another 5-HT2A antagonist like mirtazapine to inhibit the sexual dysfunction, right? GI side effects, like I mentioned, a lot of the serotonin is actually not in your brain. A lot of serotonin is actually in the chromophene cells of your stomach, all right? So that's why it can cause a lot of GI symptoms, all right? Nausea, diarrhea. Don't underestimate nausea. I know a lot of times in the book, they kind of skim over it, like nausea is like a common side effect of medications and we should just deal with it. But I've had many patients that like say once they feel nauseous, they'll never take that medication again. Think about it. Have you ever been to a restaurant and you tried one food and you felt nauseous from it? It could have been from the food, it could have been from something else, but you'll never want to go to a restaurant again, right? Because nausea hits a part of your brain that's so strongly linked to your amygdala that emotional center of your brain, once you feel nausea, you'll never, even certain smells, right? Any smells that cause that nausea effect is such a strong emotional effect also, you'll never go through that again, right? So really, really be, cautious with giving meds to your patients that cause nausea because they'll probably never take that med again. So I usually say, hey, take it with food, if you have to take lithium, sometimes if you don't want to take, any of the anti-nausea medications, right? Like, or the Entitron, you can try, ginger capsules, right? That you can get. But try to really sympathize with the patient and empathize with them that nausea is a serious side effect and that, that will make them stop medication, right? SSRIs, they can trigger mania. So be careful. A lot of times people get misdiagnosed because remember, the problem with DSM-5 is that you're going by what you see and what the patient tells you. That if a patient is telling you symptoms of depression, that, it might technically be bipolar depression, and you give them an SSRI, SNRI, and it actually can cause them to be mixed features, which is dangerous because someone can have energy and be manic and dysphoric, not sleep, and they're at high risk for suicide, or someone can be a full manic episode. I've seen both, right? Someone can go to full-blown mania and they get an SSRI, right? Bleeding risk, right? Serotonin can impair platelet functioning, all right? So be careful. Sometimes some surgeons will actually tell a patient to stop their SSRI a couple days before the surgery, right? Depending on what type of surgery it is, all right? SNRIs, like I said, measure ALT, AST to avoid risk of antidepressant-induced liver injury, all right? DNRIs, what's a DNRI? There's only one of them. Wellbutrin, bupropion. Yep, very good, bupropion. Right. I like bupropion. I know a lot of guidelines don't use it first line, but I actually use it first line because I treat a lot of like young adults and teenagers. And if you want teenagers or young adults to hate you, give them an SSRI, right? They can't have sex, right? They feel flat. They gain weight. So the good news is Wellbutrin doesn't cause weight gain, right? It doesn't cause sexual side effects. In fact, it actually helps with SSRI-induced, sexual side effects. So I sometimes if someone's doing well on SSRI, he doesn't want to stop it, but is having issues with sexual functioning, I'll add Wellbutrin on there, right? So technically, you're increasing all three neurotransmitters: serotonin, dopamine, norepinephrine, right? The only contraindication to Wellbutrin or bupropion is that it reduces the seizure threshold, right? So be careful with patients who have heavy alcohol use, who binge drink, patients who have a history of eating disorder, right? Patients who have anorexia nervosa or bulimia nervosa, right? Because they're forcing themselves to vomit. And what happens? Hyponatremia, right? Increased seizure risk, right? And guess what? SSRIs also can also cause hyponatremia. That's also a side effect to make sure you measure sodium levels. The body tends to respond pretty well to slow reductions in sodium, but when you have very big reductions at a time, then the seizure risk is much more, all right? So sometimes people will have like hyponatremia that's happening over time and they don't have seizures because their body's kind of adjusting to it. But once it goes below 135, then of course there's a risk for that, right? Tricyclic antidepressants, like I said, it works on anticholinergic, antihistamine, alpha blockade, right? So it can cause orthostatic hypotension, right? Then so there's two classes of tricyclics. There's secondary amines and tertiary amines, all right? All that really means is that like the tertiary amines tend to have more side effects. Secondary amines tend to have less side effects, all right? So if you were going to use tricyclic, I would probably lean more towards nortriptyline, discipline. All right, they're less anticholinergic, less antihistamine. Then patients tend to tolerate them better. Any questions? No. DNRI, Wellbutrin, bupropion, good medication for depression. I like to use them first line, even though a lot of literature will say use SSRIs first. But like I said, it's my population. I don't really want to give my patients weight gain, sexual dysfunction. And as long as they don't have heavy alcohol use and a history of seizure risk, I use Wellbutrin first line, or I combine it with SSRIs. All right. Bipolar disorder, right? Even though this is not a diagnostic class, just know that all you need is to have one manic episode technically to be bipolar 1, all right? You can have bipolar 1 and never had depression at all. That's a trick question, right? Sometimes I'll ask that in the test. Once you have a full-blown manic episode, you're not sleeping, flights of ideas, impulsive gambling, impulsive spending, risky sexual behaviors, right? Sometimes they might have some psychosis there. That qualifies for bipolar 1. Bipolar 2 tends to be less days, all right? But, people think that bipolar 2 is a milder version of bipolar 1, but they're actually not. I've seen people do really bad on bipolar 2. The problem with bipolar 2 is it gets misdiagnosed for MDD a lot more because the depression and the mania they kind of mix. People have mixed features and it's very hard to treat, all right? Even though bipolar 2 it also tends to be the most prevalent. FDA-approved medications for bipolar disorder, all right? Valproic acid, valproate, Depakote, all right? To memorize valproic levels, lithium levels, and carbamazepine, I'm going to give you a very easy cheat sheet. Half a dozen to a dozen, half a dozen to a dozen, half a dozen to a dozen, 6 to 12, right? 0.6 to 1.2, lithium, all right? 60 to 120, valproic acid, all right? 6 to 12, carbamazepine, half a dozen to a dozen, all right? Obviously, some labs have different, parameters, but if you can remember that, you'll know that 0.6 to 1.2 is a regular lithium level, all right? 6 to 12 is a regular carbamazepine level. 60 to 120 is a regular valproic acid level, all right? What should we know about valproic acid? It's FDA approved for bipolar mania, all right? Doesn't really cover for depression, right? So if someone has bipolar mania only, bipolar 1, valproic acid monotherapy might be a good option for them, right? Lithium. Even though here it says it's FDA approved for bipolar mania, there's a lot of studies that show it also covers for bipolar depression. But obviously, since I'm teaching you guys, we're only going by FDA indication right now. So in a test exam, it would only be used for bipolar mania and maintenance, all right? But in clinical practice, it could be used for all three. Lamotrigine, trick question, is only FDA approved for maintenance, but there's a lot of studies that show that lamotrigine is very effective in bipolar depression, and I use it a lot for bipolar depression. Carbamazepine is only FDA approved for bipolar mania, right? I'm not going to read this all to you. You guys can read this yourself, but just know valproic acid, all right, can be loaded, and so can lithium can be loaded, all right? So it's usually 20 to 30 milligrams per kilogram, divided into 3 doses, depending on how much they weigh. I used to do this a lot in inpatient hospitals. Since I work outpatient, I don't do that as much anymore. But the good news about loading is that you can get someone to a therapeutic dose pretty quickly, all right? Especially if they're very violent and psychotic, all right, or aggressive, manic. Right. Valproic acid was synthesized from valerian root, right? Which is a very good anti-anxiety medication. So valproic acid can help with people who have anxiety. If someone has mania and they're also anxious, you might be able to get by by giving them valproic acid, and also might help with their anxiety, all right? For perinatal psychiatry, valproic acid is not a very good medication because, it inhibits folate, it lowers folic acid levels, higher risk of spina bifida. It's also something called a histone deacetylase inhibitor, HDAC inhibitor. What is that? What is HDAC? Remember, there's methylation and acetylation in the Stahl book in the first chapter. I won't go into detail about it, but know that HDAC is needed for cell division, all right? So if you give someone an HDAC inhibitor, in theory, it's like a chemotherapy agent, right? Some people give valproic acid for chemotherapy too. It stops. That's why sometimes people will lose hair with valproic acid, right? Patients will be on it. Hey, I'm balding now, right? It also can suppress bone marrow. So it has a lot of side effects. You have to monitor it. Remember, 60 to 120, 60 to 120, valproic acid level, all right? Only for bipolar mania, all right? It comes in liquid form, which is good because if a patient is inpatient and they're cheeking, you can give them liquid form. It tastes nasty, but they can take it. The problem with the liquid form is that it's absorbed in the stomach. So it causes more, GI side effects of like nausea, right? Remember, the more that it's absorbed distally to the stomach, the more, the more it'll cause more diarrhea or constipation. So if someone's having nausea and they're taking it, I'll probably give them delayed release. All right, it's a capsule that makes it be delayed, and so it's dissolved in the small intestine, right? Valproic acid is also very important. It's highly protein bound. What does that mean? Highly protein bound. I'm sorry. Why is that significant for us? If a patient is homeless, right, doesn't have access to food,
We'll have a
and
higher.
they're malnourished and the albumin levels are very low, what's going to happen? The valproic acid is going to spike up, right? Remember, what doesn't get bound to protein, to plasma albumin, is going to reach it to the brain, right? So if they're getting a healthy diet, they're eating fine, you do a regular valproic acid level, right? Let's say, I don't know, it's 100. Now they're having side effects, but you do a level, it still says 100. But just because you don't know how much is actually bound to the protein now, you can actually do a free valproate level and it'll actually show you how much is going up there and you can adjust accordingly. So a free valproate level could be ordered if a patient is outpatient and they have unstable housing, right? And they're having side effects from the valproic acid, right? When you do a regular valproate level, it gives you, just the regular valproate level, not the free level, right? So remember, if there's any fluctuations in the albumin levels, be careful because valproic acid will not bind to that. It's not going to be enough albumin for to bind to, and they're going to have toxicity, all right? Which can lead to encephalitis, right? Confusion. And, in inpatient, we used to give them the medication, they would drink it and they would poop it out. I can't think of the name of it.
Lactulose.
Actually, yes, lactulose, yeah. All right. Any questions about valproic acid? No? Okay. Very good for aggression. We use it off-label sometimes in schizophrenia if a patient is very violent, because what happens is it sedates people. Remember, like I said, it's related to valerian root, so helps with anxiety, and also works on GABA. So remember, GABA is like a benzodiazepine-like medication, so it calms people down. So sometimes if patients are assaulting, staff in the hospital, we load them up with valproic acid and we put them on olanzapine for their mania, right? Because it works with aggression and sedates them, calms them down, right? We call it a snow day. You guys heard that term, snow day? Lithium, right? I'm a very big proponent for lithium, right? I'm actually going to talk about lithium for 10 minutes because I love using lithium and I feel like it's a medication that's underutilized right now. People are scared about using it. And of course, lithium, any medication that's not used prescribed appropriately is a dangerous medication. But lithium is one of the few medications that's actually been studied to reduce suicidality, right? So why would you not offer that to patients, right? It also stops cell apoptosis, right? Which is programmed cell death, so it's neurogenetic. It helps with neurogenesis, right? So they are studying lithium right now in Alzheimer's dementia, right? Because Alzheimer's dementia, the plaques and tangles kill off neurons. So why can't we give someone a medication that might prolong that, right? Or keep those connections. Right, lithium is a natural salt. A lot of the farm reps now will come to your office and say, hey, why are you using lithium? It's an old medication. Why don't you try our new medication, right? That's because lithium is unbranded and there's no money involved in it anymore, and it's so cheap that, of course, they don't want you using it. But just because it's cheap and unbranded doesn't mean it's an inferior medication. It's a medication that if someone doesn't have good insurance, they can still afford to pay out of pocket for it, right? I had a patient that lost their insurance. I think they paid $10 a month for a 60-day supply of lithium to give them 60 per month. Probably get cheaper than that. Lithium, like I said, the level is 0.6 to 1.2. All right. Lithium does have side effects. All right. It can cause cystic acne. So again, the population that I work, if I have a teenager or a young adult who's prone to acne, lithium might not be my first choice, right? Especially if they have cystic acne, because it causes your sebaceous glands to increase secretion of oil, right? It also can worsen psoriasis. So be careful with that. Everyone has history of psoriasis or, cystic acne. It also can, impair kidney functioning, right? So make sure you check GFR. So if GFR goes below 50, usually, we'll try to stop lithium. But unless lithium is the only med that's saved this person's life, then you might have to keep it on, right? It also can cause hypothyroidism, right? And sometimes it can also cause hyperparathyroidism, right? So make sure you check calcium levels. All right, so if someone develops hypercalcemia, so lithium by itself will cause a mild hypercalcemia, right? But if it's constantly going up, then I would probably send them to, the primary care doctor or to an endocrinologist to rule out hyperparathyroidism, all right? So check calcium levels, check TSH, rule out there's no thyroid dysfunction there. Make sure you check TSH before you start the lithium, right? This is a question I love to ask students. I'm probably going to ask it to you in your exam, all right? Patient is on long-term lithium use for mania, right? Levels are normal. After about 6 months to 1 year, they start developing depression. You do a lithium level is the same. What's the next step? Checking TSH, right? Ruling out hypothyroidism, all right? Especially if they're having issues with what? What are symptoms of hypothyroidism? They have what? Cold intolerance, right?
Yeah.
Heat intolerance, sorry, heat intolerance. Hypothyroid, no, cold intolerance.
Cold intolerance, yeah.
You're right, cold intolerance, sorry. If they have those symptoms that are outside of depression, I would probably rule out TSH, all right? Now, the interesting thing is TSH levels in patients who have mood disorders and TSH levels for people who don't have mood disorders are actually different. So there's a very good book that I'll write it down. I'll send it to you guys. You guys can read it. It's actually the first book written on the subject. It's people who have treatment-resistant MDD and treatment-resistant bipolar depression. And they argue that if patients have a TSH above 2.5, you should push it down lower. Now, if someone has TSH 2.5, you go to any endocrinologist or primary care doctor, say it's fine, your thyroid is normal. But if they have treatment-resistant depression, you actually augment them with thyroid hormone and you bring it down below 2.5, and they actually respond to the antidepressant medication much better. All right. So that could be a strategy that you might use with patients who are treatment-resistant. They've tried numerous antidepressants to do a TSH on them, and it's above 2, let's say it's 3.5 or 3.1, which is normal. I will give them thyroid hormone to bring it down. And actually, I've done this with some patients. They've had very good response. Before you even do ECT or TMS, right? Or ketamine. Try this first.
Can I ask, sorry, quick question.
Sure.
So like if you've had a situation like this and maybe you've tried to bump them back to their primary to manage the thyroid and they say, no, thyroid is normal, it's fine, I'm not going to prescribe. You would prescribe the levothyroxine and manage it?
Yes, I have. Yeah. And actually, I have that book that I
I feel
told.
like I see this all the time, especially with postpartum women and
Yeah, it goes through both. Yeah, it happens too with that. Yeah, it's across. Yeah.
primaries won't do anything with it, but I'm like, if we could just bring it down a little bit, I think it would really help.
The good news is that book that I showed you actually has a letter with the studies that show that's on that letter. All you have to do is change it. I've sent this to a few endocrinologists and they've been on board with me. So it has a letter, you can photocopy it, put your name on there, and you can send it to them.
Which
If
book?
you have any questions, evidence-based. Yeah. It's called
Sorry.
I have it here somewhere. It's called The Art and Science of Thyroid Supplementation for the Treatment of Bipolar Depression, but it also talks about MDD there, by Dr. Kelly, Kelly. It's the only book written on the issue. Very good book. It's actually helped me treat a lot of treatment-resistant patients also. Right. Once you become a psych NP, technically we're specialists, right? So you have to find ways to get patients better based on the fact that we have very limited medications for mood disorders or any disorder, right? So thyroid supplementation, right? Folic acid, right? Doing MTHFR if you want, figuring out if they have that gene deficit, right? And then if they do, you give them Deplin, right? These are all advanced techniques that you might have to use to get your patients better. Right? Lithium should be dosed all at bedtime. All right. Any specialist will tell you that. The reason why is because it preserves your kidney function. All right. If you give lithium twice a day, which you might have to in the beginning if they can't tolerate the nausea, but once they're stable, you try to move it all to bedtime because every time you give lithium, right, it peaks and it troughs, right? Every time it peaks, your kidney is working extra to metabolize and excrete that lithium. So if you only give it once at night, the half-life of lithium is about 21 to 24 hours, depending if you give ER release or not. You're giving the kidneys a couple hours to rest, all right? So another side effect of lithium is polyuria, all right? If it happens a lot at night, I usually tell them, after 4 o'clock, maybe limit your amount of water that you drink. All right, if it gets really bad, then sometimes I'll send them to the primary care doctor to rule out other stuff, all right? Eventually, it can progress to nephrogenic diabetes insipidus. Right, so be careful of that. And people they're not able to concentrate their urine and they're constantly peeing, right? There is evidence that giving amiloride, a diuretic, can help with that, but I personally never done that myself. I've seen it done inpatient, so I would usually refer them to a nephrologist or, primary care doctor to manage that, all right? Especially if lithium is the only medication that works for them, all right? So lithium, check thyroid, kidney functioning, check calcium levels 0.6 to 1.2. All right. Usually once someone's stable on lithium, I usually check it every 6 months once they're stable. Every time I adjust lithium, I usually check a level. Right. Takes about a week, right? Because like I said, half-life is 24 hours. So 5 half-lives, 5 days. I prefer extended release, even though, some studies show that IR might be safer for the kidneys, but extended release tends to have less GI side effects and tends to be tolerated better, even though the half-life is a little bit longer. ER tends to be, better tolerated. But I do have some patients on IR and they're doing fine. So IR half-life is like 18 to 21 hours. ER is about 21 to 24 hours on average. All right. IR, safer on the kidneys apparently because it's shorter half-life, gives your kidneys more chance to rest. ER, better tolerated because it has less GI side effects, right? Because it's not peaking as fast. Obviously, the atypical antipsychotics could be used for bipolar disorder, right? I'm sorry, carbamazepine. Sorry about that. Carbamazepine is a very strong inducer, so be careful if someone gives you carbamazepine or puts them on carbamazepine, it's going to induce all those CYP enzymes, all right? It's a pan inducer, so it inhibits almost all the CYP enzymes. It also induces its own metabolism. So usually a week to 2 weeks of being carbamazepine, I would do a level, all right? Because it might be, remember, 6 to 12 is normal level. It might be 10. A week later, induces its own metabolism. It might be 5. And the patient's not going to be stable anymore. You might have to adjust the dose because over time, it induces its own metabolism. It also can cause hyponatremia. All right. All right. It causes something called symptom of inappropriate ADH. Right. So what happens? You have too much ADH, your body retains water, you're flooded, and it's going to cause sodium levels to drop. All right. So be careful because sometimes we do see patients on carbamazepine and SSRIs, even though I personally don't like to use it. But remember, they both can cause hyponatremia. So obviously, if you're giving two meds that have that same side effect, they're at higher risk for that. So be careful with that. All right. I would probably check sodium level more frequently. All right. Olanzapine, atypical antipsychotic, very good for mania. Comes in IM form, so we like to use it, right? Patients usually respond pretty quickly. Very strong antihistamine, anticholinergic. Main side effects, sedation and weight gain, right? Out of all the atypicals, it causes one of the most weight gain, that and clozapine, right? Olanzapine fluoxetine combination. Even though I did tell you guys that SSRIs can cause cycling, for whatever reason, the olanzapine with the fluoxetine combined, maybe the olanzapine balances out the fluoxetine's activation. It's been approved for bipolar depression. I personally have never used it because the thing is patients gain so much weight on the olanzapine that it's not really a good option for me. Bipolar depression, I'd rather use lamotrigine, which doesn't cause weight gain. But again, that's just my preference. All right. Risperidone, bipolar mania, it's a very strong D2 antagonist. Quetiapine is the only FDA indicated medication for bipolar 2. That's important to know. Right? Like I told you guys, a lot of these new meds that come out, they say, oh, it's for bipolar depression, right? But has ever been studied in bipolar 2 depression? Probably not. Quetiapine is one of the few meds. There's only two of them, quetiapine and lumateperone, Caplyta are the only two that have actually been studied in bipolar 2. Doesn't mean you can't use the other ones, but if you want to go by evidence base, quetiapine and Caplyta. The only problem with quetiapine, it's also metabolically, toxic to patients. It can cause, elevated triglycerides, it can cause weight gain. Ziprasidone tends to be less on the metabolic burden, all right? Ziprasidone and lorazepam, which is not on here, tends to have less weight gain. Right? The only thing about ziprasidone, there's caloric restrictions, right? So I think you need 450 calories to take before you get ziprasidone. Or else, if you take ziprasidone without that 450 calories, you don't get full absorption. Aripiprazole, partial agonist, bipolar mania, even though people do use it sometimes for bipolar depression. Yeah, it's been studied and hasn't really worked. And for maintenance also. Right. Acenapine, I've never personally used, but it's a peen, and I heard that it comes in sublingual form. But I don't know what the difference is, why a patient would want to take sublingual over a pill. I don't know. I've never used it. Any questions? Really no Depakote, lithium, carbamazepine, all right? Because those are some, very used meds a lot. Know that carbamazepine is an inducer, right? Know about the hyponatremia or carbamazepine. Know that you have to check the level again in 2 weeks after. Depakote, valproic acid, know that it's highly protein bound, all right? Teratogenic in women of childbearing age, you be careful with that. Lithium, patients who have impaired kidney functioning, be cautious with that. Patients who already have. So if someone's on lithium and they develop hypothyroidism, would you stop the lithium? No. What do? You just supplement it, right? Olanzapine, with the weight gain, if someone does very well on olanzapine and they don't really want to stop it, I usually add metformin, all right? The thing about metformin is that it's better for prevention than it is for reduction. Someone's not going to lose weight. but it might help mitigate weight gain. All right. Mechanism mood stabilizer, all right? It's gonna make sense when I go back to what it's good for, right? Like I said, valproate, aka Depakote, works on voltage-sensitive sodium channels and enhances GABA, right? Anything that works on sodium channels and enhances GABA usually helps with mania. That's why it has anti-manic properties, right? It also blocks reuptake of GABA, increases GABA, contraindicated in pregnancy. Carbamazepine does the same thing. Works on channels, right? Calcium, sodium, potassium channels, also enhances GABA, all right? This is important. Patients of Asian ancestry, all right, or even are mixed, I still do it. You do a genetic testing called HLA-B1502. All right, I'm going to give you a good say. HLA-B1502, no carbamazepine for you. HLA-B1502, no carbamazepine for you. That means if you're positive for HLA-B1502, I'm not going to give you carbamazepine because that means you're at higher risk. I think 10 times risk of developing Stevens-Johnson syndrome. All right, unless you don't like the patient, then sure, give it to them and lose your license, but do it. Right? HLA-B1502, no carbamazepine for you if you're Asian ancestry. All right. Lamotrigine, voltage-sensitive sodium channels, but look, it reduces glutamate release. So it's actually a glutamate antagonist. What's another glutamate antagonist? You know, ketamine, right? What's ketamine for? Is ketamine for mania? No, it's for depression. So if you remember that, lamotrigine is only effective in maintenance, but it also works for depression because it works on glutamate release, right? It blocks glutamate release. Carbamazepine works on channels and it increases GABA, and so does valproate or Depakote. Therefore, it works on mania. All right. Lamotrigine, the important thing, make sure there's a titration period. Usually it's 25 milligrams for 2 weeks, 50 milligrams for 2 weeks, 100 milligrams for a month. All right. The reason why you have to do a very slow titration is because people are at higher risk of developing Stevens-Johnson syndrome. All right. That happened when neurologists were prescribing lamotrigine for seizures as an anticonvulsant. They still do. But back in the day, they were loading up people on lamotrigine because they knew it was a good anticonvulsant, right? For specific seizures, it's not a generalized anticonvulsant. It doesn't cover all the seizures, but for specific seizures, it does. When they loaded people on Stevens-Johnson, people were developing skin rashes, and some even developed Stevens-Johnson and died. So that's when they realized that a slow titration might be safer. If someone's on lamotrigine and they're stable and they miss more than 5 days, they have to restart from the beginning. That's also important. So say someone's on lamotrigine 200 milligrams, right? And they go on vacation and they forget their bottle. They come back to you a week later, say, hey, can I get a new prescription for 200 milligrams? You say, no, I'm sorry, but we have to restart from 25 again. It's a pain in the ass, but you tell the patient, look, you know, Stevens-Johnson is very dangerous, right? Do you want your skin to fall off? Right? It's an autoimmune response. The risk of developing Stevens-Johnson, last I checked, was like 1 out of 3,000. Right? 1 out of 3,000 patients. Developing a macropapular rash or skin lesion is actually 10%. Most patients will develop, not worst patients, I shouldn't say that. A lot of patients will develop a rash on lamotrigine. Just make sure that you look at it. If you're not sure if it's a Stevens-Johnson rash, I would refer them to their primary care doctor. Stevens-Johnson rash tends to appear a lot on the neck, on the face, right? It's accompanied by a fever and myalgia, joint pain, all right? If they have any of those, any systemic signs, I would probably stop the lamotrigine right away. If you're not sure, stop the lamotrigine, right? Or send them to a primary care doctor to have looked at, right? A lot of times it's a macropapular rash, they give us some hydrocortisone and it goes away, but better safe than sorry. All right. Also, ask them if they have very sensitive skin, or ask them if they started on a new detergent. Right? I had a patient like this too. They developed a rash, but around the same time. So when someone's starting a lamotrigine, I tell them a few things, right? Be careful with starting new perfumes, right? And be careful with starting new soaps or detergent. Because anything that's sensitive to your skin, I can't tell if it's a lamotrigine or that new thing that you started. So usually during that month titration, I say stay away from any of that stuff. All right, that's important. All right, because the risk of skin rash. Another important thing, if someone's on Depakote and you add lamotrigine, right, there's an interaction there. Depakote interferes with metabolism of lamotrigine, right? They compete for the same, it's not CYP enzyme mediated, it's actually phase 2 metabolism, but you don't need to know about that right now. So just know that if someone's on Depakote and you add lamotrigine, let's say someone's manic, right, and they have Depakote on board, now they have depression, and they're doing well from the mania when they were on Depakote, you want to add lamotrigine, you have to start lamotrigine at half the dose. At double the titration. Half the dose at double titration. Half the dose, 25 milligrams for 4 weeks. 50 milligrams for 4 weeks. All right? Half the dose at double the titration. All right? If not, they're going to be at higher risk of developing Stevens-Johnson because technically the Depakote is going to interfere with lamotrigine metabolism. Therefore, they're getting a higher dose of lamotrigine than you want them to have. All right? So if someone's on Depakote and you're adding lamotrigine, it can be done. I've done it. It has to be half the dose and double the titration. All right. Any questions for that? No. Good. All right. Any questions? I'll go for like 15 minutes because it was a meaty subject. But... So the test, I want you guys to know, which medications, mood stabilizers could be used for mania, which mood stabilizers could be used for depression, right? What are some monitoring parameters, right? I might say, what do you need to check for before starting lithium, right? Someone's been stable on lithium, what do you need to check, right? Someone's on lithium 1.4, what do you do? That's lithium toxicity, right? You have to stop it right away. Right? Signs and symptoms, I'm sorry, of lithium toxicity, coarse tremors, right? Coarse tremors means that they're shaking at rest. Fine tremors means that it could be postural tremors. You hold it out and they're doing mild. That's usually from that's just from regular lithium use. That's usually not toxicity, right? Usually I give them a selected beta blocker like atenolol. It doesn't cross the blood-brain barrier. It can help with fine tremors, right? Low amplitude, high frequency. Those are usually a way they describe fine tremors in lithium. So low amplitude, high frequency. All right, so low amplitude, high frequency. GI side effects, change of mental status, right? Confusion, and they're on lithium. Definitely do a lithium level. Right? Someone's an athlete. What happens if remember, lithium is a salt, and your body can't tell the difference between what's regular sodium, right? Sodium chloride or lithium chloride, right? So what happens is if someone is dehydrated, your body's going to preserve salt, but it's not going to know the difference between sodium and salt, right? Sodium and lithium, I'm sorry. So therefore, your lithium level is going to go up, right? Dehydration is going to cause increased lithium level. So they have to make sure they stay hydrated. All right. Drinking coffee and they pee out the lithium, it's actually going to drop lithium levels. I know that you're going to say, well, coffee causes dehydration, right? But normally it's not going to cause that much dehydration. What's going to happen is you're going to pee out the lithium first and the lithium levels are going to drop. So caffeine, someone drinks a lot of coffee, their lithium levels might drop. All right. Dehydration, lithium levels are going to go up. All right. If someone has any headache or pain, do not take NSAIDs. I know there are some NSAIDs out there that do not affect lithium level, but there's so many that do. Just a blanket statement, I just say take Tylenol, as long as they're able to take it, all right? But NSAIDs can increase lithium level, all right? Some blood pressure medications, calcium channel blockers, angiotensin receptor blockers, those can also increase lithium level. So make sure that if they're on it, I would probably do a lithium level and work together with their cardiologist or primary care doctor to find, a good balance of it, but those can also increase lithium levels. So dehydration, increase lithium levels. All right. High sodium diet, changing their diet. High sodium, right? What's going to happen? Their lithium levels are actually going to drop, right? Low sodium, your body's going to retain salt. Can't tell the difference between sodium and lithium lithium levels are going to go up. All right. Know those interactions. So usually when I start people on lithium, I'll spend a half hour just talking about all this, right? Stay away from NSAIDs, all right? Try to limit your caffeine use. You can drop lithium level, all right? Your diet, keep it pretty consistent, right? If you're a college student and now you lost your job and you're eating ramen noodles all day, I would probably do a lithium level and check because your lithium level might drop from all that sodium you're taking, right? Any questions?
So for the HLA-B 1502, would you always check that for before?
Anyone has any Asian ancestry? Yes, I would. Yeah. Especially if someone's mixed, you never know. I would just check it. Just throw it in there. Especially if you start carbamazepine. I've only done it once because I've only started one patient with carbamazepine. I personally don't like carbamazepine because, like I said, it's an inducer. It messes up the regimen. It's hard to kind of balance it out. It's also causes hyponatremia. It can cause white blood cell depletion also, similar to how Depakote does. So if someone's on both, which can happen, someone could be very manic, and for some reason they can't tolerate a very high Depakote level, and they have to add carbamazepine on there. So I would check CBC more frequently because you have double the risk of developing, white blood cell suppression, right? Or bone marrow suppression, which affects all of that. Red blood cell, white blood cell, and platelets.
I've seen some pretty low platelets for people on Depakote. At what point do you stop? 30?
It really don't. Is it inpatient? Is it inpatient or outpatient?
No, outpatient. Yeah.
Yeah. I mean, are they bleeding? Are they like? I guess.
No.
How old are they? Yeah.
I actually can't remember the person. I just remember the scenario. Yeah.
It's tough because, like I said, in psych, a lot of times other specialists will say just stop the psych meds, but if they're stable on the Depakote, you have to do a risk benefits analysis and kind of see, would stopping Depakote cause worse things, and you have to kind of like balance it up. I mean, if they've been functioning with a low platelet for a while and their body's kind of used to it, see if it's trending down or see if it's stable. Because remember, also with like white blood cell count, right? It's funny. I had students and we had a patient who was on clozapine and their ANC was consistently below 1500, right? So per guidelines, you would have to stop the clozapine. But when I reviewed their chart and I looked at the trend, they always, even before the clozapine, they always had a low neutrophil count, right? And they happened to be of African descent. So I sent them for genetic testing. I sent them to a hematologist and they did genetic testing and they confirmed that he had what is that called? Benign ethnic neutropenia. So therefore, since he had Ben and we documented it and the genetic testing confirmed it, I was able to keep him on the clozapine without having to stop it. And the parameters then, if it goes below 1,000, then yes, I would stop the clozapine. But, if regular people don't have Ben, it would be 1,500. But yeah. So again, sometimes it's trending. You kind of want to see the trends. That's why, like, when I do blood work, I always want to see the trends, like what's going on here, as opposed to one static, like sodium levels, right? So by the way, everything that's in the reading is fair game. So I know it's impossible for me to cover the whole book. I'm trying to give the gist of everything. If you watch all of my videos on YouTube, because again, I do the lectures based on what questions you ask me, right? But maybe other students ask me other questions and it kind of elaborates a little bit more. So just if you watch all my YouTube videos, it'll cover pretty much the whole spectrum of what I wasn't able to cover today. All right. If you have any other questions, you can ask me. I know it's a lot of material. I know it's a lot, but you can do it. Other students have done it. And actually, the last year's cohort did it in 6 weeks. You guys did it in 8 weeks. They did it in 6 weeks. An extra 2 weeks. Yeah. We actually, since we had an extra week, I was able to separate anxiety disorders and schizophrenia. They expected me to teach anxiety disorders and schizophrenia in the same in the same week, which is I thought was not fair, but I had no choice. Do you guys feel like the style book is understandable a little bit? It's the fact that I'm like explaining it. I know sometimes it could be a little complicated, even though he does use a lot of like pictures and stuff, but I'm hoping that the way I explain it gives you a little bit different perspective and it makes it a little easier too.
Yeah, it's really dense, but it's also very good. Yeah. Like I have to like step away from it sometimes if I'm like reading it for too long. But
Since you guys are NPs already, it's a little bit easier. Like I taught this last semester and it was all, RNs and they had to really go step by step. Like I'm kind of accelerating it a little bit with you guys. I'm assuming that you guys already practice and know understand this stuff. But of course I can always slow it down too if you need to. I'm just, whatever you guys want me to do. Go faster or slower. It's up to you.
I think you're doing very well. I just think you talk very fast.
It's a lot of material. I have to squeeze it in though. I'm talking.
No, I know it's good. No, I mean you're getting everything.
Well, it's getting recorded, so you can always, but some of my students used to play it in like 0.75 on YouTube. So you can always like play it
That's a
back.
good idea. Yeah. That's a good idea.
Listen, I can repeat, if you watch one of my videos, I think for the cohort that it's 6, I've repeated the dopamine pathways, I think like 6 times in that one lecture. So I mean, I have no problem repeating stuff over and over again.
In the first lecture, you repeated it?
The
first one?
For the last year, if you go on my YouTube channel and you watch.
Yeah, I watched it. I'm watching your videos. They're very good.
I'm like, you guys remember Teddy Ruxpin? That teddy bear back in the day where you put a cassette tape and it just like. That's what I feel like, because I've been teaching this course and I'm like repeating myself over and over again. I kind of like, that's why I like it when you guys are engaged and asking me questions, like clinical questions, because if not, I'm just going to repeat the same stuff I've been repeating for 2 years. And to me, that's boring. Like when you guys ask me questions, we can make it more relatable to you. It makes more sense.
Sorry, what was the other one that was FDA approved for bipolar 2 aside from Seroquel?
Caplyta, lumateperone. Caplyta, Caplyta, lumateperone. Yeah.
How judicious are you with taking EKGs on people you put on Seroquel? Like,
Since I work outpatient now, whenever I get lucky and I'm able to get them to go to their primary care doctor, sometimes it's like once a year, twice a year. But if they're going, I usually try to throw it in, right? You never know. Yeah. Yeah, a lot of the antihistamine, anticholinergic can really prolong QT. I think that's something a lot in psych that, we take for granted, but as people get put on more meds, it gets worse. It compounds it. We'll go for another 5 minutes if you guys have any other questions. The Depakote-Lamotrigine interaction is very important, all right? Remember, if someone is on Depakote, you have to start Lamotrigine at half the dose, all right? HLA-B testing for carbamazepine is very important. The induction of CYP enzymes for carbamazepine is very important. How long does it take for someone with bipolar depression usually take to get diagnosed with bipolar depression? You know how long, on average? To get the right diagnosis. During the first time they get diagnosed to when they actually get the real diagnosis of bipolar depression. 10 years, a decade. People are going to different specialists or primary care, getting put on SSRIs, SNRIs, none of it's working. So if there's a loaded family history, they have a history of being, activated, quote unquote, by SSRIs or feeling worse than SSRIs, right? Acute onset, I would probably, lean towards a bipolar depression. I know SSRIs are prescribed a lot because they're very easy to prescribe, but they're overprescribed and it's actually causing more harm than good. Because then patients come to me, they failed in like 3 or 4. Remember, every time someone fails on a medication, you're changing the phenotype of that disease almost. So if someone has MDD and now they've been put in 3 or 4 SSRI trials, they're getting mixed features, they're getting rapid cycling because you thought it was MDD, but it's actually bipolar depression. Now it's very hard to treat because now they're a rapid cycling bipolar 1 or a rapid cycling bipolar 2. If I would have caught them in the beginning when it was a clear cut, not saying I would have done any better because maybe I wouldn't have got that history, but the sooner I get the right diagnosis on the right treatment, the easier it is to treat somebody. Once someone's rapid cycling, it's very difficult to treat them. Because remember, it takes weeks for the meds to work. And if they're cycling every week, you're not even getting a chance for that med to work. By the time that med works, they're already in their next cycle. They're already manic, right? You put them on antidepressant because they're depressed. By the time the antidepressant works, right, quote unquote, like lamotrigine, they're already manic and you're not giving them cover. Now you have to give them Depakote and now you're like catching up. But that's why sometimes people with rapid cycling, they're on like 3 or 4 medications. Because, we're trying to catch all these different symptoms. And if they're a poor historian and they live alone and you don't have anyone in the family to tell you how long their episodes were and they can't tell you, you're kind of working on intuition, which is not a good way to work, but sometimes we have to do that. So you pretty much load them up with everything. Put them on Abilify Maintainer, put them on Depakote, you put them on lithium, right? And they have everything on there. Put them on benzos to sleep. And there are some patients that might need that, but if they do it, if you were able to put them inpatient, really watch their trend and see, that's why we do a mood chart sometimes. And you can see in the mood chart, you can time your meds a little bit better. So if you guys notice, I'm very big on precise psychopharmacology, right? I want you guys to practice very precisely because I don't believe in giving extra mechanisms for no reason, right? Like even though quetiapine is being used a lot, we call quetiapine the salt and pepper of psychiatry, right? You can sprinkle a little bit of quetiapine there. They can't sleep well, I give them quetiapine. They're a little agitated, they have dementia, I give them some quetiapine, right? They have a little bit of depression, they put some quetiapine, right? I don't know if it's depression or bipolar, let me give them some quetiapine. But you're giving them antihistamine, anticholinergic. Do they really need that? Maybe they only need the 5-HT2A antagonism. Maybe they really only need the active metabolite quetiapine, which is norquetiapine, which is a norepinephrine uptake inhibitor, right? Or you need a little bit of D2 blockade because there's also a D2 antagonist. So I mean, as much as we can, be as precise as possible, right, with our medications. Don't over-medicate patients. Like I always say, you can kill a fly with a hammer. You probably destroy your desk. Why not use a newspaper or your hand? I know an inpatient, they tend to use the heavy duty weapons because, the faster we get them out, the happier the administration is. But Do you really have to bomb people with 30 milligrams of olanzapine every time they get manic inpatient? Maybe not. And then they bring them to me, and I have to try to help reduce the 30 pounds that they gained while they were inpatient for a month of quetiapine 30 milligrams.
I saw a stall video that, if I'm getting this right, the way I digested it, was that 33% of people respond to an antidepressant. You're the first antidepressant that you start them on, and it seems that that number trends down second and third agents. Is that a function of the phenotype changing, or is that just the population trend?
I would say probably a little bit of both, you know. No, I try my best to get them on the right med, right? Like I said, because every trial, even in psychosis, right? Every antipsychotic they fail on, the higher likelihood they're treatment resistant. You might have to put them on clozapine. So the key is maximizing treatment and getting them to a good dose if there is an early response. So usually there's a 20% 2-week rule, right? If you give someone a medication within 2 weeks, there should be at least a 20% difference or improvement, I'm saying. If there's no improvement, then obviously you should adjust it. You should either increase the dose or switch the medication, depending on what it is. So I think sometimes the longer that people wait on subtherapeutic doses, yes, it can cause a phenotype change, right? And then therefore you're treating something that's a little bit different, right? Someone who's depressed, or I'll give you a good example, right? Someone who's depressed for a long time, you just keep insisting, because I don't want to prescribe meds because I'm worried I'm a new graduate. I keep insisting they just do the CBT or do therapy first, right? Now they're anxious because they're so depressed that they're anxious of finding a job. Now they have anxiety and depression, right? Now their friends are like, hey, what's going on with this person? Why are they leaving the house? And their family's talking bad about them. Now they have anxiety about that. Now they develop PTSD about leaving their house. Now they have agoraphobia. They don't notice how it kind of compounds. Now they're drinking alcohol to cope with that. Now they have, substance abuse problems. So like, it's kind of intuitive, but you want to treat it early because the longer that you wait, it just keeps progressing, right? You don't really want. Now, we are going to talk about, this isn't part of the curriculum, but this is something I want to instill in you guys because I want you guys to be good practice. We're going to talk a little bit about, it's called the diagnostic hierarchy, right? When you have a patient that has substance use disorder, who has trauma, who has bipolar disorder, and has, I don't know, OCD. How do you know what to treat first without making the other worse, right? Am I going to treat the OCD first? Maybe not, because I might make the mania worse, right? Am I gonna, treat that stuff if they're still drinking alcohol or still using cocaine? Probably not. I might have to, get them to stop using first, right? So there's a hierarchy that you need to treat first, because if not, you're gonna worsen the other stuff, right? We'll talk about that a little bit later on towards the end of the semester, and I'll give you guys case studies of like different patients with different diagnoses, and we'll figure out what do you treat first, right? Obviously, I have to teach you guys all the classes of meds first and the diagnosis a little bit, but once we get that, maybe the last lecture, we'll talk about diagnostic hierarchy, all right? All right. So I hope you guys enjoyed the lecture. I know it was a lot of material. Please just read through it again. All right. We'll only have 2 tests. It's just going to be a midterm and final. All right. So if there's anything not clear, you can email me. I have no problem jumping on a quick Zoom with you guys and explaining it again. Watch the YouTube channels again. All right. And reach out anytime. All right. Have a nice weekend. Take care.
Thank you.